when I started my treatment, which is was steroid treatment, it threw me for six, emotionally, physically. It was a bit of a shock, but like I said, I'm really lucky I was diagnosed by the right person in the right hospital at the right time. And as patients of rare diseases, we generally have to educate ourselves because we have to educate others, whether they're GPs, clinicians, nurses, our families. We generally have to advocate for our own health. There's still much to also learn about ITP. We're still treating the symptoms, not the actual cause. So there's still 1,000 things that we need to, if not more, that we need to learn about ITP. But, we just need to educate ourselves and arm ourselves with as much information as we can. In relation to ITP, I suppose it was around the 18-month mark when I decided to start the charity that it started to become a bit more of a fascination for me to learn a little bit more about what others were experiencing, what treatments were out there to educate myself. During my treatment, my patient journey, I've been on nearly every treatment possible or at that time. So I've experienced a lot of treatments now as well. So I can talk from personal experience when it comes to different treatments. If people ask me personally, what did you think of this, or has anyone had experience with this treatment or that treatment? I talk from personal experience. I never give medical advice. It's not my job. I'm not a clinician, but I like to be able to provide patients with just a little bit of understanding and support and information that I suppose I didn't really have as an ITP patient myself. The introduction of the new THANS treatment guidelines for Australia and New Zealand is the first one here in Australia and New Zealand at all. Originally, we were working off the international consensus guidelines, which meant that not every treatment was available. Some of the information wasn't relevant to Australia, so on and so forth. So it was quite wishy-washy. And I say that with a lot of love in my heart. I've got a lot of respect for the people behind the international guidelines, but having Australian guidelines show clinicians that ITP is important, so important that they have their own guidelines, but it then arms patients to then put the guidelines in front of their clinicians and their to show that this is the treatment path that we should be looking at. One of the big things which we advocated for was the inclusion of the quality of life in those treatment guidelines. You have to take the patient's quality of life into consideration with every single treatment, every single part of that patient journey. Splenectomy may not be the right thing for this particular patient at this particular time, but another treatment might be. So taking that into consideration on what is right for that individual patient is extremely important, and how that treatment is going to impact the patient is extremely important. And we're really proud of those guidelines. The guys at THANS, Rob Bird, Phil Choi, and the rest of the team did an amazing job, absolutely amazing job, and we're so excited to have them here in Australia. So one of the big things that it's part of our journey at ITP Australia, and one of our missions and one of our strategic directions is to push splenectomy down the treatment protocol here in Australia. It's something that I've personally raised in parliamentary inquiries. I've actually put it to federal ministers that you're asking patients to remove an organ on the chance that it may work, maybe, instead of giving them a pill or an injection. Frankly, it's not good enough. In the future, for ITP Australia, our goal is to continue to advocate for patients, not just on treatments, but obviously there is such a depth of treatments that are coming through the pipeline, not just here in Australia, but internationally, that can improve a patient's journey, their quality of life and their overall diagnosis. But the most important thing for us when it comes to treatments for ITP patients, and especially in the future, is that the first thought is quality of life. That has to be the first thing that is always considered, regardless of any treatment that is given to any patient ever, has to be how is that going to impact their quality of life, and having that open discussion with a patient. And that's the most important thing. I'd like that in the future for that to just be a common occurrence. We don't think about it. Clinicians don't think about it. It just is. So we're hoping in the foreseeable future that, we can make some serious change for patients.